A human hand is built for an extreme set of contradictory tasks. It has to act as a solid block capable of absorbing massive kinetic loads, while simultaneously serving as an instrument of surgical precision. Making all of these competing functions possible requires a highly specialized mechanical interface, the radiocarpal joint, commonly known as the wrist. In textbooks, it is classified strictly as a synovial, biaxial ellipsoid joint, often called a condyloid joint. Looking at this anatomical diagram in Figure 10.23, we can see the specific bones that make up this ellipsoid connection. The articulation happens directly between the radius and three specific carpal bones, the scaphoid, the lunate, and the triquetrum. Geographically, it forms the exact bridge between the distal end of your forearm and the proximal row of bones inside your hand. An ellipsoid joint sacrifices bony stability for biaxial mobility. To keep the hand from simply dislocating under pressure, the joint requires a massive secondary network of ligaments and soft tissue. Before analyzing that soft tissue, we have to strip the joint down to bare bone to see how the articulating surfaces fit together. The upper surface acts as a broad, concave receiving dish. This dish is formed by two continuous structures, the inferior surface of the lower end of the radius, paired with the articular disc of the inferior radio-ulnar joint. Noticeably absent from this direct connection is the ulna. The ulna ends at the articular disc and doesn't participate in the true wrist joint articulation. Below this receiving dish sits the lower articular surface, forming a segmented convex curve. This simplified 3D animation illustrates the exact structure. A single broad concave dish at the top rests directly on three separate convex spheres at the bottom, the scaphoid, lunate, and triquetral bones. A solid upper surface resting freely on a multi-part lower row is a significant bony mismatch. This geometry allows highly fluid, multi-directional motion, but also creates an inherently fragile mechanical link. To compensate for that bony mismatch, the joint relies on passive restraints. The foundational layer is the articular capsule, a fibrous sleeve completely surrounding the entire connection. Figure 10.24 maps this capsule's thick bands, clustered on the anterior palmar side. The broad palmar radiocarpal ligament anchors the distal radius to the scaphoid, lunate, and triquetrum. Beside it, the palmar ulnocarpal ligament travels downwards, attaching to the lunate and triquetral bones. If we examined the back of the hand, we would find the dorsal radiocarpal ligament. Compared to the dense palmar webbing, this dorsal structure has distinctly weaker structural integrity. Extending from the outer styloid processes are the radial and ulnar collateral ligaments. Unlike the thick collateral ligaments in knees, the ones stabilizing the wrist are poorly developed. This uneven distribution of soft tissue is an evolutionary necessity. This palmar strength bias exists to catch your body weight, preventing joint hyperextension when you fall forward onto an outstretched hand. The structural ties holding the bones together are only part of the anatomy. The radiocarpal joint is also a critical transit corridor for the hand's operating equipment. This cross-section reveals heavily packed anterior flexor tendons in synovial sheaths, with the median nerve resting dangerously superficially in front. Posteriorly, extensor tendons pass through dorsal sheaths, while the radial artery routes along the lateral edge. The joint itself draws its intrinsic blood supply from the anterior and posterior carpal arches, and receives its innervation locally from the anterior and posterior interosseous nerves. Because of this density, the wrist functions as an anatomical bottleneck. It's a highly congested space where any internal swelling from surrounding tendon sheaths will immediately compress the vulnerable median nerve. With the passive restraints and transit corridors mapped, we can look at the active muscular drivers that manipulate this ellipsoid joint under load. Flexion, bending the wrist downward, is driven by the flexor carpi radialis and flexor carpi ulnaris. Extension, pulling the hand backward, shifts the workload to the dorsal side, utilizing the extensor carpi radialis longus and brevis, along with the extensor carpi ulnaris. Moving the hand side to side requires a different mechanical approach. Abduction, or radial deviation, demands a synchronized lateral pull from both the flexor and extensor carpi radialis. Adduction, or ulnar deviation, mirrors this exact logic on the medial edge. It combines forces of the flexor and extensor carpi ulnaris to pull the hand inward. Complex multiplanar deviation isn't achieved by specialized individual muscles acting alone. It is executed by coordinated antagonistic pairings pulling simultaneously across the central ellipsoid fulcrum. Flowchart 10.4 outlines 4 clinical pathologies. A heavy fall snaps the distal radius, causing a Colles fracture. The anterior bottleneck causes carpal tunnel syndrome when swollen sheaths compress the median nerve. Excess loads tear palmar ligaments, causing sprains. Finally, rheumatoid arthritis inflames the synovial capsule. These textbook pathologies are not random diseases. They are the direct mechanical consequences of the wrist's specific biological architecture. The radiocarpal system is an unstable bony mismatch, strapped by palmar heavy ligaments, driven by antagonistic muscle pairs, and threaded with vulnerable neurology. In the radiocarpal joint, every mechanical advantage for the hand creates a corresponding structural vulnerability for the wrist. True clinical mastery requires viewing anatomy not as a static list of terms to memorize, but as a dynamic, interconnected kinetic engine where every structural asset carries a calculated clinical risk.